Good morning, good afternoon, and good evening to everyone joining us today. Welcome to the World Breastfeeding Week 2026. Today's webinar, Strengthening What Works, New Evidence to Accelerate Investment in Breastfeeding, is brought to you by the World Health Organization, UNICEF, in partnership with the Global Breastfeeding Collective. I am Dr. Altrina Mukuria Ash, a global health specialist and an international board-certified lactation consultant, and I'm pleased to serve as your moderator today. Before we begin, there are a few housekeeping notes that I want you all to be aware of course. We offer interpretation in English, French, and Spanish. And to access the interpretation, click on the interpretation icon. And if you don't have that, click on More. And then under More, you will see interpretation, and you can select your preferred language. There will be closed captioning in English for delegates using Zoom app on the computer. To view live captions, click the CC icon and select Show Subtitle. There we have the interpretation. Sorry, I moved too fast. And closed captioning, there you are. Now to ask a question. Okay, please click on the Q&A button. And if you don't have that Q&A button, again, go to the More, your three dots that say More, and then you'll see Q&A under that. And if you put your questions in and then who you are going to address that question to, you put that in and then they will respond to you in the question and answer box. And at the end, we'll have a little time for a live question and answer. Please note that this webinar is being recorded. Okay, so let me share with you the agenda. We'll start with opening remarks, followed by a video featuring the voices of mothers. From there, we'll set the stage with the Global Breastfeeding Scorecard and then we'll hear what evidence shows actually works. And then we'll walk through the findings of an updated global investment case. I'm really excited about that. We'll then turn to a donor perspective, followed by country-level perspectives from India, Ghana, and Mexico. And then we'll close with a call to action and some time for a question. All right, so let's get started. It's my pleasure to introduce Dr. Luz Maria de Vigil. She's the director of the Department of Nutrition and Food Safety at the World Health Organization. She'll bring the opening remarks on WHO and UNICEF. Dr. De Vigil is an epidemiologist with 20 years experience across the public, private, and intergovernmental sectors, and has authored more than 150 peer-reviewed and policy publications. Her full bio is available in the chat. So I'll turn this over to you, Dr. De Vigil.
Thank you very much, Altrina, and welcome everyone. It is my pleasure to greet you on behalf of WHO, UNICEF, and the Global Breastfeeding Collective. Let me begin by restating why we are here today. Breastfeeding is one of the most powerful and cost-effective interventions for child survival, maternal health, and human development. Early breastfeeding and exclusive breastfeeding protects children and infants from diarrhea, pneumonia, and other infectious diseases. If infants who are not breastfed are more likely to die in childhood, particularly in low and middle income countries. But the truth is that this fact is also true in high income countries. We have seen positive developments in this area. And I think that it's important that we reflect on the wins, but also we don't give up on the work ahead. Over the last years, from 2012 to date, we have seen a remarkable progress in exclusive breastfeeding over the first 6 months of life, from 37% to 47%. We almost met the global target for breastfeeding, which is a remarkable success. And because of that, member states felt more ambitious and decided to extend the target and be more ambitious and say we can reach 60% of exclusive breastfeeding during the first 6 months of life. But also we have seen positive trends in breastfeeding in the first 2 years of life, from 38% to 50%. So we know what works. We need to have policies that protect the right of women to breastfeed, skilled health workers, a health system that is ready to provide that support for women, community-based counseling. There are serious interventions that are highly cost-effective that allow women and are make more feasible to make the right choice in terms of breastfeeding for women, for their families. Everyone, I think, has a role to play, and I think that that's exactly the scope of this conversation today. Understanding what our role is, how we can help others understand what their role in supporting and promoting and protecting breastfeeding is, and also to discuss the benefits that it has. Breastfeeding is one of the interventions with the highest return on investment. Per each dollar invested, it's estimated that is an economic return of $59 over time as a result of lower healthcare costs, improved cognitive development, higher educational attainment, and increased lifetime earnings. So the earnings are not minor. But also, we have to talk about the most dramatic case. Breastfeeding helps prevent 400,000 deaths every year for children. And we almost never talk about maternal mortality, but it also prevents 140,000 maternal deaths every year. So it doesn't matter the angle, economic, humanitarian, life-saving, breastfeeding meets all the key points. So UNICEF and WHO are calling countries to integrate breastfeeding interventions into antenatal, perinatal, and postnatal healthcare services, improve maternal healthcare services, of course, to be able to support and provide quality breastfeeding support for women and newborns, expand community-based counseling and peer programs, and fully implement and enforce, and this is critical, the International Code of Marketing of Breast Milk Substitutes. We are going to hear about investments also on paid maternity leave and supportive workplace policies. So we have today clear actions, clear wins, and clear examples of how this can be made. And can be done by everyone. So I get back to you, and I'm looking forward to learning from all the speakers today.
Thank you so much, Dr. DeRigil. And participants, let's say thank you to Dr. Rigil through the reactions. Since we cannot talk in the chat, you can send up hearts and claps. Thank you very much. How much she informed us of where we stand today. So now let's hear directly from mothers themselves. Let's hear directly from mothers themselves. We have a short video, which really, listening to them, we learn why we are here today.
J'ai réussi à allaiter grâce avec toute l'équipe qui était formée et qui répondait à mes demandes, à mes sollicitations jour et nuit avec beaucoup de bienveillance.
Mình đã cho con trai ti được 39 tháng rồi, bởi vì mình đã cho con ti được ngay từ những ngày đầu tiên sau khi sinh, cho nên hành trình cho con ti mẹ thực sự là rất đơn giản. Mình mong rằng là tất cả các nhân viên y tế đều có kiến thức đúng về sữa mẹ để có thể hỗ trợ những người mẹ có khẩu cho con ti đúng ngay từ những ngày đầu tiên.
When I had some difficulties, they said, you'll do that, don't worry, you will do that.
كنت أعاني من قلة إضراب الحليب، ومع أخصائية الرضاعة أعطتني بعض الإرشادات والتوجيهات من ضمنها خطوات فعالة لزيادة إضرار الحليب.
The pediatric doctor came to assure me about my preterm baby's 26 weeks, and she told me she just need 1 ml from the colostrum. Since that time, my baby complete her breastfeeding journey for 2 years.
The help I wish I had from healthcare providers is advice on breastfeeding, physically showing me how to do it.
32 lần dược sĩ, đa số những dược sĩ cùng nghề với mình chưa được cập nhật những kiến thức đúng về sữa mẹ.
Unfortunately, I had a lot of misinformation that confused me.
임만실에서 간호사 선생님이 제게 우유 수유를 하면 아가 체중이 줄 텐데 괜찮나요? 라고 물으시길래 제가 무척 혼란스러웠던 기억이 있습니다.
Los pediatras me dieron una información errada y me dijeron que debía darle de lactar a mi bebé cada 3 horas.
이게 태어나고 완전 모유 수유 희망한다고 했었는데도 굳이 3시간 아니면 새벽에는 콜 없이 분유로 수유했던 게
I had lovely nurses that sat with me, helped me to breastfeed, encouraged me.
ولدت ولادة قيصرية، أحضاني إياها ورضعتها رضاعة طبيعية. بالنسبة لأنها هي preterm، النيرس علمتني أحتسب الحليب.
Cảm ơn nhân viên y tế được hướng dẫn tự vú đầu tiên và được hướng dẫn về ý nghĩa của sữa mẹ.
ባለሙያዎች አሁን አገልግሎት የማገኘው 10 እስከ 12 ጊዜ በቀን መጥባት አለበት ልጅ ሌሊትን ጨምሮ ማለት ነው።
Na zo asibiti awo ma'aikatan lafiya suka bani shawara. Yaro na ya tashi da kuzarin jikin shi kuma ba cututtuka.
وجوزني طيار وأنا صرت بريزة الطبان وكماليتي.
ولله الحمد، من قبل ومن بعد تمكنت من الرضاعة. أرشدتني إلى أهمية الرضاعة الطبيعية وكيفية مص الطفل للحلمة.
Toàn trực tiếp nhờ sự hỗ trợ của đội ngũ tư vấn viên sữa mẹ, mình đã vô cùng biết ơn tất cả mọi người.
Agradezco mucho todo eso y valoro mucho.
It just made all the difference with all 3 of my babies.
ខ្ញុំកូនដោយទឹកដោះផងដែរខ្ញុំសង្ឃឹមថាបងប្អូនស្ត្រីគ្រប់រូបនឹងទទួលសេវាកម្មនៅមន្ទីរពេទ្យ
da shawarar da ma'aikatan lafiya suka bani saka da muna godewa. Allah ya ci gaba da muna godiya sosai akan shawarwarin da suke ba mu. Allah ya saka da alheri.
والحمد لله زادت نسبة إدرار الحليب لدي. شاكرة قسم الرضاعة الطبيعية على مساعدتها في الاستمرار على
Gracias por todos los retos que pudimos superar juntas.
Nhưng chúng tôi không thể làm điều này một mình.
That was great to see all those moms. And this is what I do on a daily basis, talking to and listening to moms. And I see all those hearts coming up. You feel the same way I do. Those voices of mothers were great. So now, and we appreciate them giving their time to share with us. So now it's my pleasure to introduce to you Fatmata Fatima Sese. She's a nutrition specialist for early childhood nutrition at UNICEF headquarters in New York, who will set the stage with the Global Breastfeeding Scorecard. Fatmata manages the infant feeding portfolio at UNICEF and has 18 years of experience in maternal, infant, and young child nutrition in both development and humanitarian settings. Over to you, Fatmata.
Thank you, Altrina. It's my pleasure. We've just heard directly from mothers about their breastfeeding experiences. And the Global Breastfeeding Scorecard really allows us to step back and look at these experiences at a global level to understand where progress is being made and where additional support is needed. Next slide, please. So the Global Breastfeeding Collective, which we all know, led by UNICEF and WHO, identified 7 priority actions, and this range from financing maternity protection to stronger implementation of the code, breastfeeding counseling support services, community-based programs, and better data systems. The scorecard is built around the collective's 7 policy priorities together with the country's progress on breastfeeding practices. Next, please. As some of you may know, the scorecard has been published annually since 2017, and it now covers 194 countries. It basically combines data on breastfeeding practices with information on policy and program implementation, really allowing us to track progress towards the 2030 target set by the Breastfeeding Collective. And importantly, it helps us to understand not only whether breastfeeding rates are improving, but also what may be contributing to that progress. Next, please. So for today, I'd like to highlight some of the key findings of the 2025 scorecard to really set the stage for this webinar. As we can see on the slide here, over the past 5 years, continued breastfeeding at 1 year has increased from 67 to 76%, while continued breastfeeding at 2 years has risen from 38 to 50%. This is particularly encouraging because continued breastfeeding, as we all know, often receives less attention than exclusive breastfeeding. Yet, this is the period most heavily targeted by aggressive follow-up formula marketing. Exclusive breastfeeding is also moving in the right direction, and today 47% of infants under 6 months are exclusively breastfed globally. This represents meaningful progress, but we are still short of the target of 60% by 2030. And one area where progress has stalled is clearly early initiation of breastfeeding, with only 48% of infants are breastfed within the first hour of life, which is well below the 70% target. And given that more women than ever are delivering with skilled health personnel present, this remains a major opportunity for us all for improvement. Next slide, please. This is also another encouraging slide to see the rapid progress that is achievable with commitment and support. Between 2015 to 2019 and then 2020 to 2024, we've seen that 15 countries increase exclusive breastfeeding rates by at least 5 percentage points within just 5 years. And these countries started from very different places. Some were already performing well, while others started from a much lower baseline. While we all know there is no single recipe for success, these countries demonstrate that meaningful progress is possible when breastfeeding is prioritized. And the good news is the momentum is continuing. And we have seen it at last year's Nutrition for Growth Summit. We have 24 countries making new commitments to strengthen breastfeeding support. Next slide, please. But the obvious question that we should ask ourselves is, what drives this progress? We've seen breastfeeding outcomes, they do not improve on their own. They improve when mothers and families are supported by the right policies, the programs, and investment. And this is why the collective established the 7 policy and program indicators and set ambitious targets, but achievable by 2030. And these indicators really allow us to assess whether countries are putting in place the systems needed to protect and support breastfeeding. And the breastfeeding outcomes we have just discussed earlier are therefore only part of the story. To sustain progress, we also need to understand the policy environment behind this result. Next slide, please. Of course, we do know that measuring progress requires reliable data, and the scorecard draws from multiple sources, as you can see from the 2 slides here. The implementation of the code, we use the latest code status report together with UNICEF's Nutri-Dash reporting system. And for maternity protection, we rely on ILO data. And for information on breastfeeding counseling, this comes from UNICEF Nutri-Dash data, while the other program and policy data come from the World Breastfeeding Trends Initiative, which is coordinated by IBFAN. Together, these sources really provide a comprehensive picture of policies, programs, and systems needed to support breastfeeding. But also, the question is, what do this policy and program data show? Next slide, please. As we can see, the policy and program data reveal both progress as well as significant gaps. Financing is one huge gap. As we can see, only 4% of countries currently receiving at least $5 per live birth in donor funding for breastfeeding, compared to a 25% target. On maternity protection, only 1 in 5 countries guaranteed paid nursing breaks and breastfeeding facilities in the workplace, and only 1 in 10 meets the international standards for paid maternity leave. But on a positive note, we've seen that the implementation of the code is moving in the right direction. As of 2025, we have 33 countries having measures that are substantially aligned with the code, and this has further increased to 37 countries in 2026. The overall message here is clear. Stronger policies really remain essential if breastfeeding rates are to continue improving. Next slide, please. I want to draw a little bit of focus on the funding here. As we can see on the slide, many low and middle income countries have the greatest need for support, but had the least funding. So the important move here is more domestic investment is required, and continued donor support are needed to expand breastfeeding programs to reach more families, because without sufficient funding, even the best policies and programs cannot deliver the full impact. Next, please. And to continue, here are some encouraging results. As we can see here on breastfeeding counseling and community support programs, we have seen progress, but on the monitoring side, this is still a challenge, with only 40% of countries having collected data on exclusive breastfeeding in the last 5 years. And funding for data collection, as we all know, continues to decline. But better data really helps us understand what is working, where gaps remain, and where investment can have the greatest impact. Next slide, please. So to close, I would like to leave you with 3 short messages. First, we have seen that progress is possible, and we are seeing it happening across very different contexts. And second, the countries making the greatest gains are investing in the policies and programs that support mothers and families. And thirdly, important gaps remain, particularly in financing, maternity protection, implementation of the code, and data systems. Government and donors must match the momentum by increasing investment in breastfeeding. And with that, I will hand over to Altrina. Over to you.
Thank you so much, Fatmata. Everybody, let's send up a clap, a heart for Fatmata for setting the stage for us there and letting us know where we are and the progress we've made thus far. Now, moving on to Amir Yaparvar. I'm pleased to introduce him. He's a senior advisor for early childhood nutrition and development in UNICEF's Child Nutrition and Development Global Practice. He will be walk us through what the evidence shows works. Amir has worked with UNICEF for close to 2 decades, holding nutrition specialists and chief posts across Lebanon, the Europe and Central Asia region, and Afghanistan. His full bio is available in the chat. Over to you, Amir.
Thank you very much, Altrina and colleagues. Good day, and so great pleasure to meet all of you. Congratulations for World Breastfeeding Week 2026. This annual event just reminds ourselves that investment and work on breastfeeding is a non-stop agenda for all of us. It requires maintenance, and that's just a reminder. So as Altrina mentioned, I'm Amir. I'm working for UNICEF as a global lead on early childhood nutrition development. And so pleased today to take you through on what works and how well for breastfeeding. So in this session, we are going to take you through 6 core interventions that the evidence shows can improve breastfeeding outcomes. And these interventions span, as you can see on the slide, from the health system support pillar to communications and counseling, and also to the issues around employment support and a friendly environment for mothers in the different settings. And this basically is going to be supported by evidence and, of course, on the strength of each of these contributing to the outcomes for breastfeeding. In the next slide, I will just immediately dive into the first intervention that is around the skilled breastfeeding counseling and education delivered through health services and communities. The global strategy on infant and young child feeding calls for counseling for integrated across the continuum of care and not limited only to the maternity wards. And this includes antenatal care, well baby, care for sick children, immunization, nutrition sessions, and so forth. WHO recommends at least 6 counseling contacts during the pregnancy and after birth, and the evidence shown here indicates that counseling and education can substantially increase exclusive breastfeeding across different delivery settings, including healthcare facilities and the home and communities and family environment, with particularly strong impact reported for group counseling in some studies. The practical implication is that breastfeeding support could be a routine service standard with trained staff, repeated contacts, and clear referral pathways with mother-faced difficulties. Next slide, please. So facility-based counseling is essential, but it's also great if it's coupled with a community pillar. Many breastfeeding challenges emerge after mothers return home. Community-based peer counseling and mother support group can help sustain breastfeeding outcomes between the health contacts. The review summarized here found that peer counseling and mother support groups could reduce the risk of stopping exclusive breastfeeding about 29% in low and middle income countries, where community peer support nearly doubled exclusive breastfeeding at 3 months and more than tripled at 6 months. The key is continuity from facility to the community, and more than and supported beginning during the pregnancy, linked to the health services, but also bringing it closer to the households, mothers, and in the community level. In the next slide, we're going to look into the second intervention area, if you can go to that, which is implementation of the 10 steps to successful breastfeeding through baby-friendly hospital initiatives. We all know about the background, so I'm not going to repeat on that. The 10 steps require facilities to have and monitor breastfeeding policy, ensure staffing competency, counsel women and families during pregnancy, after birth, support immediate and uninterrupted skin-to-skin contact and early initiation, helping mothers establish, maintain breastfeeding, avoid unnecessary supplements, rooming in, supporting responsive feeding, counsel on the risks of bottle feeding, and ensuring coordinated follow-up after discharge. The evidence is consistently show better exclusive breastfeeding outcomes when maternity facilities adhere more fully to these practices. The objective should therefore go beyond one-time designation. Countries need national standards, staff competencies, routine monitoring, and continuous quality improvement to the 10 steps become part of the everyday business of maternal and newborn care in health facilities. Next slide, please. The third intervention is national mass media promotion. The global strategy calls for social mobilization, including use of mass media to promote appropriate infant and young child feeding practices. Evidence suggests that media interventions, when integrated with counseling and community mobilization, are associated with a 17% increase in exclusive breastfeeding, which is impressive. The important qualification is integration, not alone. A campaign alone may improve awareness, but behavior changes is stronger when women also have access to skilled support, enabling services, and access to skilled counseling through the health facilities. Next slide, please. The fourth intervention is effective implementation and enforcement of International Code of Marketing of Breast Milk Substitutes. We know about it. The World Health Assembly first called for restrictions on inappropriate marketing of BMS in 1981, and subsequent resolutions have repeatedly clarified and strengthened these protections. The code matters because commercial marketing can shape paternal, mothers, fathers' decision choices, influence health professionals, and undermine the confidence in breastfeeding by the mothers, caregivers, but also by the health professionals. So adoption of the legislation is only the first step. Countries also need to clearly regulate responsibilities on the implementation of the code and the national laws, independent monitoring, transparent reporting, and meaningful sanctions. The strongest results come when legal measures are accompanied by enforcement systems that can identify and address violations consistently. The fifth intervention is paid maternity leave. Next slide, please. The International Labour Organization recommends a minimum of 18 weeks of fully paid leave, while the Global Breastfeeding Collective calls for 6 months or longer. Payment is essential. As women are less likely to take leave when their income is not protected or at risk, the evidence is compelling. Maternity leave of less than 6 weeks increases the odds of not breastfeeding fourfold, while access to maternity leave is associated with a 52% increase in exclusive breastfeeding rates. Paid maternity leave is therefore both a nutrition intervention and a social protection measure, giving women the time and economic security needed to establish and continue breastfeeding. The next slide will take you through the sixth intervention, which is breastfeeding support at work. Returning to work should not force women to choose between employment and breastfeeding. Quality childcare, paid breastfeeding breaks, flexible arrangements, safe and private space for expressing and storing milk are critical measures. The ILO recommends at least one daily nursing break in appropriate facilities. Provision of workplace breastfeeding support and policies, also as you can see on the data, is associated with 8% higher rates of exclusive breastfeeding. These policies are practically important for women in low-paid, informal, agriculture, and non-standard employment who are often least protected. Governments and employers need solutions that extend beyond formal office settings and reach all working women. Actually, this was also an issue which was brought in the previous webinar, that how we could do that. So we are so also grateful to hear your voices on this. Next slide, which is basically my final message, is about how we can strengthen further the impact. So I think my final message is that implementation quality and combination is really important. Mass media campaign achieves more when coupled with counseling and community mobilization. Adoption of the code is more effective when enforcement and monitoring systems are in place and established. Of course, preventing formula samples and commercial discharge packs is not really protecting breastfeeding, but just harms at a particular vulnerable moment that families are so vulnerable and desperate. Across all interventions, the last bullet is on monitoring, which is quite important. Fatimata explained about the global scorecard on breastfeeding and also was scanning the questions about the data, the sources, and I'm so excited to see that there are more data available in many regions and many more countries, that I'm really encouraging bilateral touch points to connect those with the scorecard, making sure that the data is as rich as possible. But also at the country level, for the sake of policymakers and programmers, it's extremely important to have a strong monitoring in place to know what's happening, what's moving on, and what's not moving on, to be able to further enforce our efforts in breastfeeding. So the evidence is clear. Breastfeeding outcome improve when women receive skilled support, give birth in breastfeeding-friendly facilities, are protected from inappropriate marketing of breast milk substitutes, have time and conditions to breastfeed after returning work, and all these interventions are feasible. They're all mutually reinforcing and highly relevant to the national nutrition and human capital agendas. So I really look forward to discussions further to hear from the investment case and how we can further build a stronger advocacy to convince decision makers to invest on these evidence-proven actions. Back to you, Alton.
Thank you, Amir. Everyone join me in thanking him with your, yes, with your claps and your hearts. We really appreciate you showing us the evidence. We know what works. And if you looked at some of the references, they go back to 2016. Over 10 years, we've known what works. This is personal to me, it's professional to me, and as Amir said, monitoring is so key. What gets counted gets done. So moving on to Dylan Waters, he's going to give us the investment case. So excited to hear more from him. Dylan Waters is a senior global portfolio director of health economics and nutrition financing at Nutrition International, and he will present the updated global investment case. Dylan is a health economist who completed his PhD in health economics at University of Toronto and previously worked with the World Bank, Alive and Thrive, and the Sick Kids Center for Global Child Health. His team at Nutrition International leads the applied health economic research and modeling behind today's findings. A full biography is available in the chat. I will turn it over to you, Dylan.
Thank you very much, Altrina, for the introduction. I'm honored to be here today for this World Breastfeeding Week event to present the findings of the new global investment case for improved breastfeeding. This investment case was a joint effort by my team at Nutrition International, led by Michael Ona, Samina San, and Sakshi Jain, in collaboration with Larry Grummer-Strawn at the WHO and Fatmata Fatima Sise of UNICEF. Next slide, please. The main objective of this investment case for improved breastfeeding was to provide new data for policymakers and advocates on the question of why invest in breastfeeding, and secondly, how to invest in breastfeeding given scarce resources. Next slide, please. Next slide. Our analytical approach for this investment case analysis included a rapid review of literature looking at potential interventions, their effects, and unit costs. Then we use this opportunity to update the data set of the Cost of Not Breastfeeding tool to provide new estimates on the health, human capital, and economic consequences of not breastfeeding for this launch event. For the investment case itself, we developed several combinations of intervention packages, plus scenarios for coverage and outcome targets for the purpose of comparison. With an analytical model based on the Cost of Not Breastfeeding tool, we conducted impact and cost modeling, plus a cost-benefit analysis. Next slide, please. In the analysis, we used a country sample of 88 countries with exclusive breastfeeding rates below 50%, plus a few countries with the highest numbers of non-exclusively breastfed children. The analysis included standard assumptions on historical trends, population growth, inflation, and discount rates. We estimated the cost, impact, and economic returns of scaling intervention packages to 75% coverage in the primary analysis and full coverage of 95% in the sensitivity analysis, which you can see in the full report. Next slide, please. Based on the literature review, a set of evidence-based interventions for the protection, support, and promotion of breastfeeding were selected for inclusion in 3 investment packages. These packages, as discussed earlier by Amir, with similar titles, included a core health system support package that included breastfeeding counseling and education and the baby-friendly hospital initiative. A second package, which expanded to the core plus policy and behavior change communications, included additional provisions for a national and mass media breastfeeding promotion campaign and establishing and enforcing the International Code of Marketing of breast milk substitutes. Thirdly, the full system support package included all of the above interventions, plus provisions for maternity leave benefits and workplace breastfeeding support and policies for women working in the formal sector. These interventions support mothers and their children at various stages across the life course: pregnancy through birth, postpartum period to infancy and early childhood, and when women return to work. The impact model included effect sizes from the literature for 5 out of 6 of these interventions, all except the international code, even though it presents strong indications of an effect of national policy alignment on improving breastfeeding rates. Next slide, please. And thank you. Moving to the findings, we first present the updated Cost of Not Breastfeeding tool results based on the most recent data available to the end of 2025. Globally, we estimate that each year, suboptimal breastfeeding costs approximately 339 billion in economic losses globally. This is equivalent to 0.32% of global income. We also estimate conservatively that we incur $1.8 billion in health system costs due to not breastfeeding. In addition, not breastfeeding has a tremendous impact on the cognitive development of children, which is estimated to result in approximately 167 million IQ points lost in our children. And not breastfeeding is associated with over 380,000 child deaths and 137,000 maternal deaths each year. Results for most countries of the cost of not breastfeeding are available in the updated Nutrition International and Alive and Thrive Cost of Not Breastfeeding tool. Next slide, please. Of course, there is wide variation in the cost of not breastfeeding by region, given key drivers such as breastfeeding prevalence, under 5 mortality rates, income, and others. By region, most notably, the health consequences are highest in Sub-Saharan Africa, South Asia, and East Africa and the Pacific region. The highest economic costs relative to income are highest in Sub-Saharan Africa, South Asia, and Latin America and Caribbean region. Next slide. Next slide. With respect to the financing needs of the investment packages, we estimated that the cost to scale up these interventions to 75% coverage. For scaling up the core health system support package, we estimate it would cost approximately $6.3 billion over 10 years, or $6 per child. $4.9 per child. Scaling the core plus policy and BCC package, we estimate would cost approximately $6.3 billion over a 10-year period. And that's for all the 88 countries included in our sample. This equates to approximately $6.6 per child, slightly higher, but would have greater reach due to the policy and BCC interventions. And thirdly, scaling the full system support package would cost approximately $13.3 billion over 10 years globally, or approximately $14 per child. The highest cost interventions, as you can see on the right-hand side, are the workplace support and policies intervention, though potentially these costs could be borne in part or whole by private sector employers, as well as the paid maternity leave benefits and baby-friendly hospital initiative. Next slide, please. While that level of investment is significant, the impact of scaling these breastfeeding packages would be substantial as well. We estimate that this investment would result in a 15 to 18 percentage point increase in global exclusive breastfeeding rates within 5 years. With the Core Plus and full system support package enabling the World Health Assembly target of 60% exclusive breastfeeding to be reached by 2030. Further scaling of these packages to 75% coverage of the interventions by 2035 would see 70% exclusive breastfeeding rate being achieved by all the packages by 2035. Next slide, please. Globally, this level of investment and improvement in breastfeeding rates would lead to between an estimated 224,000 and 263,000 child deaths averted within 10 years. Each of these packages is also projected to avert approximately 160,000 maternal deaths over a 10-year period. These investments demonstrate massive potential to improve child survival, and yet there is even more impact that can be achieved with more ambitious targets, coverage, and investment levels. Next slide, please. Furthermore, this major improvement in breastfeeding rates would lead to significant human capital gains through improved cognitive development by averting up to 133 million lost years of education and averting up to 382 million lost IQ points in children. The full system support package can achieve around a 17 to 24% incremental boost in human capital indicators compared to the core package. Next slide, please. While the core health system support package cost is lowest, and it is the most cost effective, it does reach a smaller population in need. The Core Plus policy and BCC package is slightly more costly, with similar benefits per $1 invested, but it will have a larger policy and BCC reach. The full system support package is most costly and comprehensive. In terms of economic benefits, we estimate that these three packages of breastfeeding intervention, if scaled to 75% coverage, can support the world to reach levels of exclusive breastfeeding between 70 and 73%, which can generate substantial economic gains between an estimated 276 and 357 billion over a 10-year period. The cost-benefit analysis also suggests that each package demonstrates benefit-cost ratios of ranging between 27:1 and 59:1, which represents an excellent return on investment and very good value for money. Next slide, please. For policymakers, donors, and advocates, this investment case suggests that prioritizing breastfeeding interventions and maternal, newborn, child health and nutrition plans, policies, and budgets makes sense because they are good value for money and can yield substantial health outcomes for families. Country-level economic analysis on breastfeeding investments is important for developing realistic plans and attracting investments. We also recommend that the development of government-led nutrition financing strategies to increase resource mobilization for breastfeeding interventions from a mix of domestic public development and philanthropic financing sources for long-term sustainability. Lastly, utilizing cost of not breastfeeding and investment case data has shown to be effective for advocacy at all levels. Next slide. In summary, scaling coverage of the core plus policy and BCC package, which includes breastfeeding counseling and education, BFHI, code, and national mass media breastfeeding promotion campaigns to 75% coverage is ideal for meeting the World Health Assembly target of 60% exclusive breastfeeding by 2030. Further scaling coverage of all packages to 75% coverage by 2035 will allow for the achievement of greater than 70% exclusive breastfeeding rate, which will produce significant health and human capital benefits around the world. The projected cost-benefit ratios continue to suggest that investing in the protection, support, and promotion of breastfeeding is excellent value for money and presents a high and positive return on investment. Please see the full investment case for breastfeeding report for more details and visit the NI website to access the updated Cost of Not Breastfeeding tool. Next slide. I want to I thank my colleagues across NI's health economics, communications, and advocacy teams for their dedication to this project. And of course, our collaborators at the WHO, UNICEF, and the Global Breastfeeding Collective for their technical and financial support for this project, as well as Global Affairs Canada for its financial support of NI. Thank you all for your attention today, and please feel free to contact me with any questions or feedback. Back to you, Altrina. Thank you.
Thank you, Dylan. The claps and the hearts and the thumbs up are out there. We all appreciate this comprehensive look at the numbers behind the case. You really have laid it out plain and clear to us. How can we find billions for war and weapons and can't find a couple of billion for breastfeeding, huh? Breastfeeding saves lives. It gives us a smarter population. And, we may have people who will solve some of all the other problems we have to solve if we breastfed them. So thank you so much. It saves money. And the cost benefit analysis shows that it pays as well. Thank you so much, Dylan. So now we're going to go over to Dr. Olusola Sotunde, the Senior Food Systems and Nutrition Advisor at Global Affairs Canada, and she'll be joining us in a pre-recorded message. Dr. Sotunde leads strategic initiatives at the intersection of nutrition, health, food systems, and gender equality. And with more than 2 decades of experience in health systems and international development. Her bio is in the chat.
Excellencies, distinguished colleagues, partners, and friends. Thank you to the Global Breastfeeding Collective, the World Health Organization, UNICEF, Nutrition International, and all the researchers and experts whose work has made today's discussion possible. Through Canada's support to Nutrition International, we are pleased to have contributed to this important new investment case and to efforts that strengthen the evidence base on maternal and child health and nutrition. It is a privilege to join you during World Breastfeeding Week as we examine one of the most significant and impactful interventions for improving health and well-being around the world. At its core, today's discussion is about people, ensuring every child has the best possible start in life. Every mother receives the support she needs, and in doing so, strengthening the foundations for healthier and more resilient communities. The evidence presented today highlights the wide-ranging benefits associated with breastfeeding. Breastfeeding improves child survival, nutrition, cognitive development, educational outcomes, and lifelong health, while also improving maternal health by reducing the risks of certain cancers and other non-communicable diseases. Its benefits extend beyond individual health. They can contribute to stronger learning outcomes, greater productivity, higher lifetime earnings, and more resilient economies. That is why the findings presented today are so important. The updated investment case contributes important evidence on the potential health, social, and economic benefits associated with breastfeeding. It provides useful analysis for governments, development practitioners, researchers, and financing partners seeking to better understand the relationship between nutrition investments and broader development outcomes. The report also highlights the significant consequences associated with inadequate breastfeeding practices. Globally, inadequate breastfeeding is linked to substantial health and economic costs, including preventable child and maternal deaths, increased illness, higher healthcare expenditures, and lost human potential. The discussion today also draws attention to a range of factors that researchers associated with improved breastfeeding outcomes, including access to skilled counseling, supportive health services, maternity protection measures, workplace supports, stronger links between health services and communities, and broader enabling environments for women and families. We also know that progress is possible. Recent data from the Global Breastfeeding Collective indicates that 16 countries have achieved meaningful improvements in exclusive breastfeeding rates. These experiences provide valuable insights into the policies, programs, and partnerships that can support progress in different contexts. This approach aligns closely with Canada's international development objectives. Canada remains committed to evidence-informed programming that supports country-led approaches, advances health and rights of women, children, and adolescents, improves nutrition, and contributes to sustainable development outcomes. We are meeting at a moment of considerable global complexity. Around the world, the need for assistance is rising as conflicts become longer and harder to resolve. Climate change continues to affect communities and livelihoods. At the same time, development resources face growing pressures in Canada and around the world. In this environment, evidence matters more than ever. Health and prosperity cannot be achieved by any one country or institution acting alone. Progress depends on partnerships that bring together governments, multilateral organizations, civil society, researchers, communities, and development partners, each contributing their expertise and strength. Canada welcomes the findings presented today and values the contribution they make to the global evidence base on maternal and child health and nutrition. We look forward to continued dialogue and collaboration with partners as we work together to support healthier futures for women, children, and families around the world. In closing, I would like to thank World Health Organization, UNICEF, Nutrition International, the Global Breastfeeding Collectives, and all those who contributed to this important work. The evidence presented today deepens our collective understanding of the health, social, and economic benefits associated with breastfeeding and provides an important contribution to ongoing policy and program discussions. Together, through collaboration, partnership, and evidence-informed approaches, we can continue advancing better health and nutrition outcomes for women, children, and families around the world. Thank you.
Whoops, thank you, Dr. Sotunde, for that perspective from the donor community. We now turn to 3 country-level perspectives on what this investment case means on the ground. Joining us are Dr. Ashutosh Sarwa from India, Ms. Gifty Ampa from Ghana, and Dr. Michelle Unar Munguia from Mexico. Dr. Ashutosh Sarwa is a national program manager at Nutrition International India, with more than 15 years experience in maternal, newborn, and child health and nutrition. Ms. Gifty Ampa is program lead for the Maternal, Infant, and Young Child Nutrition Program at Ghana Health Service, with more than 20 years of experience in maternal, infant, and young child nutrition programming. And Dr. Michelle Unar Munguia is head of the Department of Maternal, Child, and Adolescent Nutrition at Mexico's National Institute of Public Health. Their full biographies for each panelist are available in the chat. Now let's hear directly from them. To start our first round of questions, I'll ask each panelist to share a specific investment in their country that has helped move breastfeeding indicators forward. Dr. Sarwa, what investment in India stands out as having improved breastfeeding indicators?
Thank you so much, Altrina, for this question. My answer to your question will be very much based on the recently released National Family Health Surveys and the sustainable investment from the last 2 decades. So the first indicator which we have seen improved is the early initiation of breastfeeding. And largely the contributors are the institutional delivery that has now reached to 90%. And it's an investment from last 2 decades under the National Health Missions, where cash incentives for the institutional delivery, free services to mothers and newborn, including transportation, and hospitals' preparedness for the quality birth care are the major reasons behind it. The amendment in the Infant Milk Substitute Act that closes the loophole, and it also reflects declining change in the pre-lactal feeding. So these are the 2 major indicators which we have seen improved because of the investment. Largely in the last 1 decade, campaigns like Breastfeeding Week, investment in terms of increasing the paid maternity leaves, and a lot of multi-sectoral investment has also gone in it. Unfortunately, some of the indicators that is around exclusive breastfeeding, that has not changed a lot, and we still think that its investment and constant work is really needed for the India.
Thank you. Thank you very much. And we'll move on to Ms. Gifty. Maybe you can tell us what investments in Ghana has helped to improve breastfeeding indicators.
Thank you very much, Trina, and good afternoon, everyone. So here in Ghana, we have seen an increase in exclusive breastfeeding rates from 2% in 1993 to 53% currently. And we believe these three broad factors have contributed to this achievement. We have a good enabling environment through supportive national policies like the National Nutrition Policy. We have the National Health Policy, the Universal Health Coverage Strategy. All of these highlight breastfeeding support at all levels of healthcare. We had our law passed in the year 2000. It has currently been reviewed to take cognizance of issues around social media, and this has helped immensely to restrict marketing and promotion of breast milk substitutes in the health facilities and among the general population. Our second factor is institutional strengthening. Capacity building efforts have been undertaken for all healthcare facilities. We have hospitals, health centers, community health planning services spaces, very, small health facilities, but they have all had their fair share of training and capacity building. Currently, we are working to set up lactation support rooms to improve breastfeeding counseling. The last one I will talk about here is, breastfeeding support services is way down the health structure, interfacing the community. And this has helped us with individualized counseling, home visits, follow-on support, and all of these have contributed to the achievements we have made. Thank you very much.
Thank you, Ms. Gifty. And now, shall we go on to Dr. Michelle? Maybe you can tell us what investments Mexico has made that has helped to improve breastfeeding indicators.
Gracias. Sí, en los últimos 20 años tuvimos un programa de transferencias condicionadas con atención específica a la nutrición infantil que tenía un componente específico para lactancia materna. Se tuvo capacitación a profesionales de la salud a través de la estrategia ESIAN, pero en los últimos 5 años, bueno, ese programa desaparece y ahora tenemos algunas nuevas iniciativas de apoyo a la lactancia materna, como el protocolo para estandarizar la atención en los primeros 1000 días en hospitales y centros de salud. Y tenemos también programas de lactancia materna, tanto en hospitales como en centros de salud para personas con seguridad social y personas que no tienen seguridad social, y recientemente un programa con parteras tradicionales. Y también se han desarrollado diferentes materiales de capacitación para personal de salud para atención en los primeros 1000 días y en el embarazo, así como un programa nuevo que se está desarrollando para proteger la nutrición infantil y la lactancia en situaciones de emergencia. Y por supuesto tenemos un programa nuevo, bueno, una aplicación nueva con uso de inteligencia artificial para monitorear el Código Internacional de Comercialización de Sucedáneos de la Leche Materna, que lo estamos desarrollando en colaboración con sociedad civil, academia, algunas instancias del gobierno y UNICEF. Se llama Código Lactancia México y monitorea en tiempo real el marketing de fórmulas y alimentos infantiles en medios digitales, y se ha capacitado al personal de salud en todo el país para que conozcan el código.
Thank you, Dr. Michelle. Let's move on to the next question. That's exciting about that AI work that you're doing in monitoring and making folks adhere to the code through the monitoring of digital media. Our second question is around underinvestment. So now we know what investments have led to. What are those barriers that have come up as a result of underinvestments created in India? And I would ask each of you to give 1, 2 sentence answers. Thank you.
Shall I start? Can I come here?
Yes, we're talking about India first.
Okay, thank you so much. We'll be very precise. As I mentioned that in the last decades, we have seen a lot of social and demographic changes. Rapid urbanization is the major thing which is coming. As of now, 36% of the Indian population reside in urban areas. And we are also seeing the kind of breastfeeding practices there is a clear gap between urban and poor settings. So urban settings is one of the challenges where we still need to improve ourselves. And the second thing is about as the women's participation in the workforce is also improving, that is also resulting in some of the practices like prelactal feed and continuation breastfeeding is really difficult. So these are the two major changes in terms of the beneficiary side. And the thing which is also coming is a highest contribution by the C-section delivery in the private sector. So these are the 3 critical barriers which we are able to see from the last 1 decade.
Thank you so much. And let's go on to you, Ms. Gifty. What barriers has underinvestment created in Ghana?
Thank you. So I will mention 2. One of the first one is the underinvestments have led to our inability to continuously train our health staff to generate and sustain the facility changes that occur during the training. So this has led to reduced capacity. What we are currently doing is working with the National Accreditation Agency to include breastfeeding in accreditation to give the responsibility to health facilities to take this up for sustainability. Our second underinvestment area is advocacy. Advocacy. We need to engage and engage and engage. And we are afraid that with our reduced investments in advocacy, we will go back on all the achievements that we have made. So we call for more investments in advocacy, both local and from our international partners. Thank you.
Thank you, Ms. Gifty. And then Dr. Michelle, what barriers has underinvestment created in Mexico?
Sí, la falta de un presupuesto específico para un programa de lactancia materna hace muy difícil capacitar continuamente al personal de salud y monitorear que las acciones se lleven a cabo de manera adecuada. También tenemos una subinversión para escalar la implementación de la iniciativa Hospital Amigo del Niño y para implementar campañas de sensibilización de lactancia materna a nivel nacional y escalar las acciones a nivel nacional. Tenemos que depender de financiamiento de organismos internacionales y organismos de la sociedad civil, que son los que han apoyado las diferentes acciones en lactancia materna, y no tenemos financiamiento específico para monitorear el código. Aunque tenemos esta nueva app con inteligencia artificial, hay un riesgo de que no se pueda seguir implementando si no tenemos el financiamiento específico. Y por último, decir que tenemos una baja licencia de maternidad pagada para mujeres que tienen un empleo formal, y las mujeres que trabajan en un empleo informal no tienen acceso a un programa de apoyo a la lactancia materna.
Thank you. Thank you to all 3 of you. You showed us really at the national level and even at the national level within countries what the cost is of not investing in breastfeeding and where it really hits hits you in your services and in your national policies and so on. So let's go on to the third question, which I'd like to ask you is what advice, because we have many people on the line here who are working in various countries and programs around the world that could learn from your experience. Please share with us what advice you would give for engaging donors and decision makers in this austere time that we are in. So we'll start with you, Ashutosh.
Thank you so much. As I mentioned, that the situation in India is now emerging is having a different kind of challenges. So that donor interest, based on my own experience, it will be very innovative. Should be very innovative. So as I mentioned, some of the emerging issues are urban areas, workplace arrangement for the breastfeeding, where mothers can continue breastfeeding, and it will be directly. It's not that direct investment is needed, but it should be by making advocacy, making policy level changes. So this is one area where support is really needed. The second thing is investment by the government is in the health sector is also very optimal. So investment may not be needed directly for the health related work, infrastructure, and these kind of things are very much up to the mark. So the donors' interest should also see what others gaps are there. For example, dialogues with the multiple ministries, how the laws can be influenced in that segment, and especially in the informal sector where mothers are not able to maintain breastfeeding, how strategic investment can also do. So in summary, in India, support from the donor is needed and in a very strategic direction with the emerging challenges, not the routine investment, which government of India has already done a lot of things.
Thank you, Ashutosh. And I think I want to highlight the key things you talked about, urban areas. Our countries are urbanizing at phenomenal rates, and we need to address that. We also need to address the informal sector. Those women working in the formal sector, how do they get support? That's an area where there's a gap that needs investment. And then you mentioned about gaps in policies and laws. Thank you for those key points that you brought out. So now, Ms. Gifty, can you give us advice from the Ghana perspective for engaging donors and decision makers?
Thank you. For me, I think that one of the most important things that we can do is to engage with a good design of our strategy. So looking at issues around training, the first one, implementation, and then support. So for training, if we can start off looking at pre-service training, that is one area that we should, advocate with our partners and for government funding or investment. And then also using the accreditation systems, because once it is in the health facility accreditation, the health facilities take, responsibility for that, and then they support their health staff to get the necessary training. So I would say that for training, implementation, we need to have our own strategy. Look at your country profile, the kind of health facilities that you have, and then scale the training to fit them so that you are able to, get at least the minimum for those who probably do not do antenatal care. What package would you have for them that will scale down the number of days of the training and the cost? The final one I'll talk about here, Dr. Aisawa talked about it, support for working women and the informal sector. How do we expand the support to informal sector to make sure that breastfeeding spaces are available within our markets, within our lorry parks, that when women get there, they can find spaces to sit and breastfeed safely. Thank you.
Thank you. Yes, you brought out some important points, Ms. Gifty, on pre-service training. That is so key worldwide. We can't keep doing these in-service trainings. We will be doing them forever, and we have been doing them forever, and they don't have the impact that if it was in the pre-service training of our health professionals. So key, and accreditation. that, as we mentioned, what gets counted gets done. If it's linked to your accreditation, you best believe those hospitals will be maintaining, and you won't have to keep reminding and encouraging them and going back. They will do it to hold on to that accreditation. So thank you so much for bringing out those key points. And Dr. Michelle, can you tell us, in Mexico, what advice would you give to donors and decision makers?
Y muchas gracias por la pregunta. Inversión en lactancia no es un gasto, que tiene beneficios para la sociedad, pero también para los gobiernos y para las empresas. Hemos mostrado que extender la licencia de maternidad, en lugar de ser un costo, puede tener beneficios económicos también para las empresas, para las mujeres y para la sociedad. Y también un llamado a los tomadores de decisión para que realmente se implementen sanciones económicas para quienes infringen el código. Esto es muy importante. No dinero que se recauda de esas sanciones también puede para implementar acciones de apoyo a la lactancia materna.
Thank you, Dr. Michelle, for summarizing that for us of what support is needed for actions. And thank you, audience. We'd like to help me to thank our three speakers, from Mexico, India, and Ghana for those very insightful and experiential comments that come from their experience in the countries and what they have learned and the advice they can give to us. And I hope you will take them back to your countries and start working on those as well. So as it's now time to hear from you, our audience. What questions? I've seen a lively question and answer in the chat. And so I'd like to put before our panelists a question that you have brought up. This one is on, given the strong data, and I think this is for Dylan, given the strong data on the investment case for breastfeeding, how can each of us best use this information to affect change and achieve greater investment? We'll start with Dylan from Nutrition International.
Thank you very much, Altrina, and thank you, panelists, for your comments and sharing your country experience. How can we use this data to advance investment? From the Cost of Not Breastfeeding tool experience and those investment cases that preceded it or have since been completed, we've seen this data can be very powerfully used in various ways. It can be very useful at the national level when there's context-specific data for each country, whether it's Nigeria or India or Mexico or Canada. At the national level, investment case data, cost of not breastfeeding data is very compelling. Very often, policymakers have never seen such data on the economic consequences of malnutrition or not breastfeeding specific to their context. So I think working with governments and presenting this data is effective. It can also help governments change policies and guidelines if it's integrated into national guidelines for infant and young child feeding, for example, or food systems and marketing at national level. The investment case data is also very compelling for media. We've seen newspapers and podcasters and even in the social media, this investment case data lends itself very well to being conducive at extending this message. And then in other regional investors or global investors, such as Asian Development Bank, African Development Bank, Islamic Development Bank, World Bank, are very influential in directing where investments go, or philanthropic and innovative financiers as well. So this data should be shared with them to help them, I guess, to provide guidance to them for where they should invest in what sectors, as they follow, the experts' advice often.
Great.
So that's my recommendation. Thanks.
Thank you so much, Dylan. And I want to ask Amir, can you briefly also think about that question, since you talked to us about what works? How can this data be used to best used to improve investments, greater investments at country level, knowing what works?
Thank you very much for this question and all for the great inputs from the panel. I mean, I really enjoyed. I think a lot said by Dylan. Definitely, we have to always go with the context. We have to know our context very well to know where the biggest gaps and bottlenecks are for breastfeeding in our context, in our countries, and then to start from there. Now, with this wealth of evidence generated by this amazing investment case, we have enough to scale up our advocacy on the policy, investment, financing in a domestic context. And of course, in many contexts, we are working with donors, we are working with IFIs, as Dylan mentioned. I think those are great entry points for that as well. We should also be able to track budgets, because sometimes there's expenditure, but we are unable to measure those. And when we are unable to measure those, either we underestimate it or maybe overestimate it. So it's important for us to make sure that in our metrics, we are able to measure the investments we are making on breastfeeding. And in this, don't forget that breastfeeding is not only the business of the Ministry of Health. There are costs for breastfeeding at the Ministry of Labor, Economy, and etc. And all those needs to be able to be tracked and measured. And always build alliance. So we said all that what should be done. I want just to say perhaps 3 things that we shouldn't do. And perhaps often we forget about the things that we shouldn't do. One is that we should never, ever ourselves, and also let policymakers, to treat breastfeeding as a one-go intervention. This is an ongoing public health importance, I would call it. I don't like to call it intervention, because it's a public health essential that needs to go on from generation to another. And the assumptions that if you have achieved, we are done, is just the beginning, that you can start your failure again. This requires maintenance and perseverance. The second, do not treat breastfeeding as only business of one sector, as I mentioned earlier. It's beyond only Ministry of Health. This always needs to be brought up to the table of policymakers. And the last thing is that do not apply your understanding, especially from the behavior side, of previous generation to the upcoming generation. Now we are having Generation Z becoming mothers and fathers, and the dynamics of this world is very different. Do we know enough? Let's not make assumptions on their behalf, because this is a totally different dynamic, and we definitely need to know more. Thank you very much, and back to you.
Thank you. Thank you, Amir. I'm going to throw out another question, and then I'll let any of you would be willing to answer. This one was about climate change. Can issues about climate change and emergency feeding be part of these discussions, given that we are now in a state of frequent climate and emergency? How can we talk about investments and what works in that context? Does anyone have some thoughts on that? That's a tough question, but here we are. We have earthquakes, we have emergencies all over. We see the flooding, etc., that we are seeing around the world, that people are in dire need. How can we make investment data and use that to advocate for investments? Dr. Michelle, you look like you're ready to say something.
Yes, thank you, Aldrina. Gracias, Aldrina. Sí, en México precisamente porque estamos viendo que cada vez hay más situaciones de emergencia derivadas de cambio climático, de crisis o de epidemias que están afectando a las madres y a sus bebés, se está desarrollando una estrategia específica para atención de la nutrición y de la lactancia materna durante situaciones de emergencia. Capacitado para saber qué hacer en situaciones de emergencia y las donaciones de sucedáneos de la leche materna deben ser monitoreadas y no deben dejarse acciones libres de parte de toda la sociedad, sino que la Secretaría de Salud o los ministerios de salud deben de organizar muy bien cualquier donación y proteger la lactancia materna.
Thank you. Does anyone else
Yeah,
want
just
to
to
contribute to that? I
yeah,
think
just to
you brought out.
contribute to that as
Yes,
well.
Fatmata.
We do know that breastfeeding is climate resilience and environmentally sustainable intervention, while the investment case being clearly when cover breastfeeding in in the environmentally sustainable situation and capture it as it should be. But we do know that in conversations that relate to breastfeeding, the emphasis should be about breastfeeding being safe, locally available source of nutrition, and does not depend on supply chains as well as transportation. So there is a compelling case, as always, to position breastfeeding as a climate and resilient, environmentally sustainable intervention that would make the case for a sustainable investment in breastfeeding. Whilst we do not have the clear analysis on environmental sustainability in the investment case, but the evidence is clear that investing in breastfeeding is really where we should go if we want to really focus on interventions that are climate resilient and environmentally sustainable moving forward. Thank you.
Thank you so much, Fatmata. And Dr. Ashutosh, in 2 sentences, we're short on time.
I can just simply explain the biology behind it. The climate change is resulting in preterm deliveries. It's happening. There are evidences also. And establishing a breastfeeding in the preterm, it's very difficult. So in that sense, we should also be very much prepared that the climate is resulting in preterm low birth weight babies, and ensuring breastfeeding in the low birth weight is also going to be a priority areas. So that's a comment and some thoughts I have to share with the participants.
Thank you. Thank you for sharing that. There's so much we could talk about. Unfortunately, we don't have the rest of the day. Gifty, can you say one sentence? I'll let you go.
Yeah, sure. Thank you. I think for some of the emergencies, for example, the flood situations that we've had in Ghana, people just relocate to family members. And so when the health system would need to put out an alert during such instances so that such people, women who are breastfeeding, can make contact with the health system as soon as probably they get to wherever their shelter or their safe place will be. Thank you.
Thank you. Thank you all so much for your contribution. As we close today's webinar, I would like to thank Nutrition International for the extraordinary support they have provided for this year's World Breastfeeding webinar, as well as developing the investment case. They also coordinated collection and editing of the data for us, and of the Voices of Mothers video, and created informatics. Thank you, everybody, for thanking them, sending up those results. I also would like to thank for those folks behind the scenes. This could not happen without the help of Jorgen Johnson for managing the Zoom platform, and Katie Parry for managing the slides, and Lisa Mandel for managing the question and answer, and Zemena for supporting, and Jeanette for managing all of us. Let us conclude by reiterating the evidence is clear. We know what works, right? First, investment in the comprehensive package of interventions, including the code, the baby-friendly hospital initiative, and community and workplace support. 2, close the financing gap with scaled domestic and international funding. Let's put money where our mouth is, right? What are we talking about if we don't have the money? And then third, let's align new investment with the Global Breastfeeding Collective's call to action. Thank you all for joining us today, and best wishes for the rest of your day. Continue to celebrate World Breastfeeding Week and World Breastfeeding Month in other countries. Thank you.